Genetic testing is becoming an essential tool for the diagnosis of many eye hereditary diseases. And in particular, genetic testing for corneal dystrophies may result essential in order to avoid unpredictable and dangerous tissue response following refractive surgery performed on patients unaware of being affected by some type of corneal dystrophy. In patients with corneal dystrophy, the deposits that are supposed to be pathognomonic of the disease in the initial phase could be quite difficult to be seen at the slit lamp. Also, it could be quite difficult initially to differentiate a corneal dystrophy from another corneal alteration like degeneration or dysplasia. Moreover, it could be difficult to differentiate initially the different type of dystrophies. And also, the most experienced refractive surgeons, extremely skilled, may be not completely confident in recognizing these corneal dystrophies. Therefore, in order to make a real diagnosis, there is only one way: to perform a corneal genetic test. There is now a substantial amount of information about how TGFBI protein functions in the healthy eye. We don't know exactly how the mutation of the TGFBI gene interferes, but we know for sure that it may or it does interfere substantially in the wound healing. That means that after a refractive surgery, a patient with a TGFBI mutation may seriously be affected by an unpredictable tissue response, and that could bring to a dramatically acceleration of the corneal disease or the corneal dystrophy, and also to a seriously impaired of the vision. In my practice, I always perform a gene testing in order to better diagnose and differentiate hereditary retinal diseases like retinitis pigmentosus, Usher syndrome, corneal rod dystrophy, choroideremia, Leber congenital amaurosis, and X-linked retinoschisis. I always perform an AMD genetic test by patients which are exposed to a higher risk of getting the AMD disease, in order to avoid to these patients to have during their life something to do with the risk factors they trigger the disease. I always set up a large database of patients suffering from neovascular age-related macular degeneration, in order to better select the intravitreal injection of anti-VEGF, which I believe is more adequate, or we will understand will be more adequate for having a better result, the so-called pharmacogenomic. Regarding corneal dystrophies, I always perform a corneal gene test whenever I see an opacity or a corneal abnormality that cannot be explained by a previous history of trauma of corneal surgery. I always perform a corneal gene test whenever I examine a patient with the Japan or Korean ancestry, or with a previous familiar history for a TGFBI mutation, or a familiar history of a corneal transplantation for any reason. I believe that a corneal genetic test has to be performed by any patient that is undergoing refractive surgery for two different reasons. The first one is that I would like to perform always a test which is easy to be done in order to improve the diagnosis of any patient that potentially may suffer or they may diagnose of not being diagnosed. The second point is that from a legal point of view, I believe that it could be extremely argue not having performed a genetic test on a patient that has finally been misdiagnosed for the corneal dystrophy and underwent refractive surgery. A lack of accuracy and diligence would be immediately advocated because the genetic test was already existing. It was extremely cost effective and was totally harmless.